Um, Dr. Nguyen is a statewide medical director for Centurion in Tennessee. He was introduced to me through Doctors May and Wu, who work at Centurion and who are his supervisors. And he's going to talk to us about um, advances in the management of diabetes and how to put those into place in the correctional setting. And I'll leave it to Dr. Nguyen to introduce himself further, but his brief CV was in the introduction and the the publicity materials we sent out. So Dr. Nguyen.
Good evening, everyone. I think good evening for the east of the state and good afternoon for the west of the state. My name is Viet Nguyen. I'm a statewide medical director of Centurion of Tennessee. Before I become a physician, I was training electrical engineer in Vietnam, and then eventually get Bachelor of Science in chemistry and went to medical school in the US. Trained in family medicine and work in variety settings, include outpatient, inpatient, and also urgent care addiction clinic. And just fall in love with correctional setting during COVID, and have been working for Centurion almost 5 years, and happy to be here to share the management of diabetes in correctional setting. I think this is a very bullet points to our discussion today about SGLT2, GLP-1, glucose monitoring, and insulin pumps. So let's talk about SGLT2. SGLT2 actually was FDA approval in 2013 to in 2017. There are many medications have been available in the US. We have so far we had Jardiance, Invokana, Farxiga. The benefit for SGLT2 is reduce cardiovascular disease event, reduce heart failure risk, decrease kidney progression, and also decrease hemoglobin A1C. The next slide, we're talking about SGLT2 inhibitor mechanism of action. So like everyone can see that the loop of Henry, we know that the medication of action for SGLT2 is block reabsorption of the glucose at proximal 2. So basically, you take this medication, did block the kidney to reabsorb the blood sugar, and you pee out the sugar, so you decrease your blood sugar in your bloodstream. So of course, when you urinate out sugar, there are a lot of reaction related to this. So sugar is fuel for yeast and bacteria, so you usually get UTI and yeast infection. On the top of that, when you urinate out sugar, water follow with that. So you get a lot of that you read it for this. Increase your urination can cause you get a weight loss. On the top of that can make acute kidney injury. There is some literature increased risk of amputation, pancreatitis, and also ketoacidosis. The ketoacidosis, we have to understand why we take the medication and we urinate blood sugar, we urinate out sugar, and we got ketoacidosis. The issue is if we urinate all the sugar out and you don't have enough sugar in your body as a fuel, the body start breaking down muscle, and you will become ketoacidosis. It's called euglycemic ketoacidosis. This is a good medication. There are multiple study about that, multiple research about it, but also has some limitation when you use this medication. I put really bullet point for which medication you need to use. So if a GFR less than 45, you should not use Jardiance, Invokana. There is contraindication for that. Avoid and use Farxiga if GFR less than 60. The next agent we want to talk about is GLP-1 receptor agonist. So this one is the medication. The first FDA approval actually in April 28, 2005 with the medication named exenatide. Okay. The first FDA approved for treatment for diabetes. This is a good benefit, this medication and a GLP-1 glucagon glypeptides is show a lot of benefit. One of benefit is improve the left ventricle ejection fraction. It increase myocardial contractility, improve cardiac output. It promote beta cell, decrease beta cell apoptosis, and we know the beta cell is make insulin. So it prolong life of beta cells. The beta cell can make more insulin and it can regulate our blood sugar. And A1C reduction from 1 to 2%. Right now, they have so many in the market. They get Trulicity, they get Victoza, they get Ozempic. Ozempic that right now all over the news, shortest worldwide because it's losing weight, it make people losing weight, and then we has been using it, and that reason multiple pharmaceutical company want to come up with the GLP-1 because the weight loss for this. Let's talk about mechanism of action for this medication. I think GLP-1 and GIP, the glucagon lipeptide 1 and glucose insulinotropic like peptide. This enzyme acting like incretin effect. So what it will do, I had a picture in here. I think picture worth it than more than 1,000 words. The GLP-1, the benefit will be is body weight. It decrease body weight, decrease blood pressure, decrease plasma glucose, increase satiety, decrease appetite, increase insulin, and decrease glucagon. All of this is the benefit of the GLP-1. Okay. However, there are side effects come with it. This medication is slow down your GI tract. Okay, when a patient take this medication, your GI tract is slow down. So when a patient take this, they get nausea, vomiting, they have diarrhea. That's the most common side effect. I think this side effect is so much that the people take this medication were not able to eat. When they're not able to eat much, they start losing weight. They also increase the risk of gallbladder disease, pancreatitis, diabetic retinopathy. And sometimes they can cause subcutaneous fat loss too. So these are the common adverse reactions of this medication I listed in here. So because we had so many medications for GLP-1 come out, and every single pharmaceutical drug company was make the advertising say that they are the best medication. You have so many drug rep come to your office and talk about that. You confuse yourself too, and between GLP-1 class medication and which one you need to choose for the best patient interest. So I put in one table and very, very focusing on 3 things. When I make a decision between GLP-1 medication to which one I choose, I just 3 things I look at it. It's A1C, lowering, decrease weight, and any adverse reaction. Okay, I listed out this is the table so we can compare each medication together. So let's look at Victoza. They decrease A1C sanitizer, decrease A1C intermediate, but it not make the patient lose weight much, and the GI effect is low. But we look at the semaglutide, I think it's the Ozempic, they had highest low in A1C, they had highest losing weight, but they also high for had a GI adverse reaction. So that reason, when the patient take the medication, they say, I cannot tolerate, doc. I have such so severe nausea, vomiting. We have to look at the other medication, and we can choose less GI adverse effects for the patient, like liraglutide or or the other medication. Or if the patient come in and they're demanding is losing most A1C and losing most weight, you can use it and make a decision with the medication you want to choose for the patient between the GLP-1 class, and make it one table for everyone can remember it. I think this table will help you guide the medical provider easier to choose between the GLP-1 class medication. Any question for this? The next slide, this one is the GLP-1 and the GIP dual agonist. So we know that GIP is glucose-dependent insulinotropic polypeptide receptor, and GLP-1. They have in the market, they have the medication can combine for both. But however, this combined medication, we thought if you had the component GLP-1, you also had a component for GIP, probably you do better, right? Because GLP-1 has so many good outcome for the patient, and improve cardioprotective, improve insulin creation, and also reduce the risk stroke, heart attack, and everything. So you think that if we come up with new medication and can combine GLP-1, GIP, you think that you had the better outcome. But however, there are no data since 2002 for any study from major adverse cardiac event. So there is no research to tell us this medication combined dual creatine agonist could be the better for the patient. Maybe there, but there are no research show to guide us for this. The FDA approval in 2002 for Mounjaro for diabetes type 2, and then in 2023 they are not approval for it for weight loss. Okay, the A1C reduction is up to 2.3% if combined with metformin, and the same adverse reaction risk for GLP-1 agonists. So the next question we want to ask, if you had SGLT2 is also good, GLP-1 also good for the patient, so how can we make a decision when a patient have diabetes, and how can you make clinical decision which class medication you use? I usually localize in 2 bullet points: clinical indication and comorbidity and contraindication between the two class medication to choose it. So this is another table. It's very useful to compare between SGLT2 class and GLP-1 class. SGLT2 like Jardiance, Farxiga, GLP-1, Ozempic, Trulicity. So for major cardiac events in type 2 diabetes, both of them show almost the same of the benefit for reduced cardiac event. However, the SGLT2 is also reduced the heart failure risk. I think the component of diuretic for this medication is significant reduce the heart failure risk for the patient. So if you have the patient has CHF and also diabetes, I think SGLT2 is a good one to choose over GLP-1. The SGLT2 also good for chronic kidney disease. It decreases kidney disease progression. So you had diabetes, you had the patient had diabetes, you had the patient has CHF, the patient have chronic kidney disease. I think SGLT2 is a good medication for you. Keep in mind to use it. But the A1C, however, the A1C reduction, I think GLP-1 is more superior compared to SGLT2 for hemoglobin A1C reduction. And if the patient is morbid obesity and failed the other conservative management and also had diabetes, GLP-1 is a great medication to put the patient on. I think the adverse reaction for slow down GI tract, it make the patient eat less and somehow the patient start losing weight. So when you look at the table and if the patient comes to your office or you see the patient in correctional setting and the patient had the other comorbidity, we look at it and you make decision which one did you choose. But this medication doesn't make the patient blood sugar, the hypoglycemic risk is low. There are no studies say that took the medication, the patient become hypoglycemic. There are some report, but I think the risk is really low. I think it's very useful table to keep in mind and keep it somewhere in your office when the patient come to see you and you forgot something to pull it out, look at it, and you make decisions for this. Another thing is when you choose between SGLT2 and GLP-1, because both class saw a lot of major significant reduced major cardiac event. So how can you make decision for between two of them? I also use the comorbidity and contraindication. So if the patient is elderly or geriatric patient and had a lot of UTI problem already, maybe should not and maybe don't put the patient this medication. You urinate out blood sugar. You urinate out sugar is a fuel of a bacteria, yeast infection, and you put the patient to have more UTI. It's not helping the patient. And if the patient have significant severe vascular disease, don't put the patient on this because SGLT2 increase the risk of amputation. So don't do that. Same thing with active diabetes ulcer, it make it worse. GLP-1, if the patient had MEN2 or medulla thyroid cancer, that definitely contraindication. If the patient has severe gastroparesis for diabetes already, you put this patient on this medication, it will make the patient severe nausea, extremely nausea. So don't do that. Though it's keeping in mind when you choose the medication for the patient. Any question from the audience? If
I have a
not,
quick one. And thanks for asking for questions. People can also use the chat, and we'll have plenty of time for discussion at the end. Are you
okay.
going to cover cost, because that's probably the biggest? This is both confusing and expensive, so we tend to. I think that by and large we tend to stick with the stuff that we're used to using. As an old school guy, that's me.
I totally agree with you between the SGLT2 and GLP-1. And I think the GLP-1 is way more expensive compared to SGLT2. The reason is I think the components for weight loss, so people start using that more and it costs way more. And if you look it up, the Jardian for 30-day supply for 25 milligram or 10 milligram is like $569 average. And let's look at the Trulicity. The component for Trulicity is the pricing. They come up with like 0.75, 0.13, and 4.5 milligram injection. And it is weekly injection and they give you 4 pens. It costs you about $900. So you're looking for about $300 to $400 difference between two medication already. So GLP-1 is way more expensive than SGLT2, and it's injectable. The next thing we'll get blood glucose. The next topic we want to talk about blood glucose monitoring. There are two traditional right now, a traditional glucose meter and a continuous glucose monitoring. We want to talk about that. This a glucose meter it's a dinosaur. It's long time. We use it for so long. Continuous glucose monitoring is new. It new compared to the glucose meter. Here, the glucose meter we have reader, we had the needle deploy, we had the lancer. So you have to stick your blood. You have to stick your finger stick and get your blood sample to measure it. And the FDA usually accurate within about 10%. There are a lot of potential error. It's like if you expire test strip or dirty matter inappropriate technique, it will cause the reading incorrectly. However, if you had higher level of uric acid in your body, it will cause misreading. So we had the people who had gout and their uric acid level is super high. It will interfere with insulin pathway and your reading will wrong. Okay. If you give a patient levodopa, carbidopa, the patient will have a Parkinson disease. Levodopa acting like a dopamine. When dopamine release, it make your body make more glucagon, and you make more sugar with glucagon, and reading will wrong. And when a patient take a lot of vitamin C, you take a lot of vitamin C, very acidic, and then the strip is base, so they interact to each other through your blood, and it make a reading was wrong. When you take a silo, the strip will, or the reader will make it look like a glucose molecular. So when you do that, it will cause misreading. So be careful when you have a patient and you look at the patient, history, or the patient take a lot of Tylenol. You take a lot of Tylenol, it will combine with the automatic molecular and look like a sugar molecular, and it will misreading. So you look at your patient, the medication list, look at the history, and sometimes you can figure out why is this patient reading keep wrong. Because a lot of time they thought the machine will malfunction, but actually you give the patient the medication with cause the machine misreading. This is a new continuous glucose monitoring is new. There is 4 major devices in here. It's the Medtronic, Eversense, Dexcom, and Freestyle. Okay. This thing is really good and primarily used for type 1 diabetes, but type 2 diabetes with multiple insulin injection, or history of hypoglycemic, or even though the patient has so many ER sent out for hypoglycemic, I think continuous glucose monitoring is a good way to manage the patient. The downside is it delay about 10 to 15 minutes. Okay, the reader was like, they read it this time, but actually a delay about 10 to 15 minutes. So sometimes you have to keep it in mind when you see this number. So here the picture of this, they had the transmitter, here the skin, here is the glucose sensor. So this kind of needle stick in your skin and it detect blood sugar molecular in your interstitial fluid, and it read it send your transmitter. The transmitter will send to the device, usually a Bluetooth device, so it can read the number what exactly in your blood sugar right now. And it's good for the patient care, and you don't have to stuck the patient multiple times per day. The patient like it, the patient happy with it. The next, there is multiple continuous glucose monitoring, the CGM. I put in a table. We can compare the device in the market together. There are only 4 companies to make a device. Okay. I look at the sensory wear time. The Dexcom lasts about 10 to 14 days. The Freestyle up to 14 days. The Medtronics only 7 days. The Eversense up to 6 months. This is implantable CGM. This is a newest one. So basically, this one needs to be done by a physician, a medical provider, just implant the device inside your body, and it can last for 180 days. So up to 6 months, you have to remove out and replace one. I compare each device by data transmission. So you can see most of them go through Bluetooth. And here is the alert. So they will customize the manufacturer will customize the alert for high and low glucose level. Usually the urgent low glucose level is 55. They will set it up at 55 milligram per DL. So that will alert your device. The implant CGM actually it's send out the vibration when the blood sugar too high and too low without any mobile device nearby. So basically it can detect it too low, it start vibrated. I compare each device by insertion. Some is automatically insertion. The other will be handle manual insertion, and the other one the last one, the implant CGM have to handle by healthcare provider. Compare about the calibration. Some doesn't need it. Some have to have a 3 to 4 times per day. The implant device, for 21 days, you have to require 2-finger stick. And after that, 1 time per day. So even though the implant device lasts longer, but you need to do a calibration every day. Some patient doesn't like it when they have to stuck the finger every day. Water resistant, we compare, and I'm looking for the integration with insulin pump. So if CGM will compatible with another, with the insulin pump, and we list it in here, I listed in here for all of you. The cost, I find out a cost for Dexcom and Freestyle, but the Medtronic and the Inverse and the implant CGM, the Inverse, I don't have the cost at all. So when we talk about this one, we need to talk about challenge during correctional setting, okay? So we would love to use for our inmate, but the thing is, a lot of time when you bring it up, we have to thinking about the CGM is electronic device, and some DOC considered a secure risk. Okay, the next is the cost. The cost is more expensive compared to regular glucose meter. For training and education, you have to training the inmate how to use it. And also you have to train your provider how to use it too. For the data management, you have to require the healthcare staff to understand it, to collect the data and use the data to make the medical decision. This is for provider training. Most of our provider was unfamiliar with CGM. But however, the opportunity, we had a lot of people have diabetes and its complication like hypoglycemic, DKA, hypoglycemic. I think a CGM is good for these high risk patients. It's also opportunity for telehealth. You know, we can get the data sent to the specialist, the endocrinologist. They will look at it. They send a recommendation. And also the inmate, empower the inmate to imagine your inmate say that, hey, I give you a device. You don't need to suck your finger every day. We can monitoring this. We can help you control your blood sugar. They more compliant and listen. And I think that it may empower, that's an opportunity for us in correctional setting, beside all the challenges that we're facing. And I know in Centurion, across the state, I know some states start using this for their high-risk inmate, and the outcome is significant impact for the healthcare, and also a lot of good positive outcome come out. Next, the last one, we talk about insulin pump. Insulin pump is challenging. I think during my training, I have to wrap the endocrinologist and make him to sit down to teach me about insulin pump. Believe me or not, the first time I said no, oh, I had to figure out insulin pump never have long acting, they had short acting, because first time, I will misunderstanding about that. But now today we're talking about insulin pumps. I try to talk about most common insulin pump in the US. I think the most popular in Medtronic is approved for about 7 years of age. It integrated with the sensor tree, the Guardian sensor tree CGM. They had the reservoir 1.8 ml to 3 ml. This one to where you storage your insulin, and a waterproof from 2.6 minutes to 24 hours. They had no touch screen. Here how it look like. Okay, I think it's used. It's one of the most popular. The next is Tandem. They had a touchscreen. They look fancy. They approved for age about 7 years, and it control IQ hybrid closed loop. Actually approved for about 6 years of age. They integrate with Dexcom G6. Here their volume for their reservoirs, and the water proof is 1 minute to 20 minutes only. That touchscreen, but they had no integrate with the meter. The next one we call YP Soul Pump. It's actually approved for all age. Okay, so this is good. All age can use it, not about 1 year old. It integrate with Dexcom G6 too, and I list out all the feature for you. The last one I want to talk is about the Omnipod. It approved for all age, but when I do this slide, they had no CGM integration. They don't. But however, I think in June, by the end of June the end of June this year, actually, I think they will actually finally can be integrated with Dexcom and Free Lifestyle. So hopefully you can see the usage of it across the market in the future. So when you use insulin pump, there's something that you need to consider, the factor. Security and safety consideration due to the electronic nature of insulin pump in correctional setting. It's electronic device. You have to get approved from the OC. That'd be a challenge explained for people non-medical, how patient need it, especially people with type 1 diabetes to use it. There is training education for the inmate. Most of our inmate were not not familiar with insulin pump, and I think the training education is really most important. Okay, it needs to be close monitoring and supervision for healthcare staff. And another challenge, emergency response. We have to have emergency response if we had insulin pump, because sometimes it malfunctions, sometimes whatever happened in middle of the night and in correctional setting, how can our nursing staff, what they need to be done, what they need to be do to manage these people with insulin pump, that all of this risk. I think across Centurion contract, I don't think any contract use insulin pump, and the cost is extremely expensive. That is the end of the lecture. Here the reference. Any question, any comment from the audience?
I have one.
Yes, please.
So we have lots of inmates on antipsychotics. They collaborate and orchestrate what to say so that they can get on them primarily to sleep. But them by themselves cause high triglycerides, stimulates appetite, and bad carb craving. What are your thoughts on the diabetics that are also on antipsychotics or the high triglycerides, with including the GLP-1?
So first off, you're breaking up a little bit. I only heard about to maybe half of what you said clearly. Is that your microphone or is that your connection, do you think? Did you understand the question?
So let me rephrase the question. I think your question is, we have the inmate population on antipsychotic medication, in which increase appetite, and you're asking if the patient diabetes in which medication, what might talk about medication that need to be used. That's correct?
Mostly trying to get them approved because we're treating more than one thing. Once they get on those antipsychotics, we're exacerbating the triglycerides, we're exacerbating the A1C because they keep eating things that they shouldn't. So the GLPs would be a way to blunt them and metabolically prevent them from doing it, even if they wanted to, because it makes you sick if you eat the bad stuff.
I agree with you. So we have people in our correctional setting too will put on antipsychotic, and then they gain weight, and we put in GLP-1 and decrease their appetite, increase their satiety, and they start. You can see their A1C more control, and their weight loss is better. So I think a GLP-1 would be good for this type of patient that you're talking about. I agree with you.
So how do we go about getting those approved because of the expense? Because then we deal with the utilization management part of it.
So I think it's I think regardless for UM, and I think Dr. Rich is UM physician in here. If you follow standard of care and evidence-based medicine, you just write a justification. You just write a patient right now on the, obesity and weight, on this medication, GLP-1 was benefit for this, and you write your justification. And I think if you follow the evidence-based medicine to make your justification, I don't think anyone can deny it for you. And I think I had Dr. Rich on this call. And Dr. Rich, can you give me some feedback from as a UM physician?
So what I'm going to say is this: if you have a diabetic patient who is on antipsychotics and you're seeing significant weight gain with their antipsychotic, and you have not exhausted the lower risk antipsychotics in the treatment of the psychiatric care of that patient, hopefully it is obvious to everyone that the first line would be changing to a lower metabolically detrimental antipsychotic. And there are drugs that are more and less detrimental in terms of the lipid effects, blood sugar effects, and hunger. And those medications are more expensive for psychiatry. And so this is one of the places where separate mental health and medical contracts come into conflict with one another, because what is best for the patient in that instance often is to be on a more expensive psychiatric drug and forego the GLP-1 from the medical side of things. However, if you have a patient who is stabilized mental health-wise on an antipsychotic and you have not evaluated, you are unable to, because of either their delicate balance of mental health stability, or you have used those lower risk antipsychotic options, then it is reasonable to try a GLP-1 in those patients. Actually, SGLT2s are good options as well. Primarily in those patients, you're going to have to exhaust the standard of care treatment, which is going to be metformin first. And then as your secondary options is when you're going to be looking at the GLP-1, et cetera. And if you reasonably argue to your UM advisor, hey, this is a patient with serious metabolic effects from their obesity, from their antipsychotic, this is overall going to save us money. You can often successfully argue that. We do have patients on GLP-1s in the Tennessee contract, not just because of their, not just because those patients have antipsychotic use, but it can be a good adjuvant.
Thank you, Dr. Rich. So again, I think that Dr. Rich point out very good point that we need to do a first line agent and follow step by step, and then you make it good medical justification for GLP-1. I don't think your GM physician would deny it. They cannot deny if the evidence by medicine and for the patient best interest, they cannot deny it. Okay, any other question?
I can say that the ACCP National Conference will be covering this as well around issues of and national standard of care, and I think that the discussion is only beginning in this. I think I see this, Dr. Nguyen, as an introduction to some of the stuff that we've got from national experts coming up in September in Salt Lake. And that's not just meant as a plug for the conference, but as an explanation. We'll see what we can do about getting those talks available to the public in one format or another. I had questions about the custody have concerns about continuous glucose monitoring. Are those concerns justifiable? I mean, something about the data. I mean, is there so what kind of mischief do inmates get into with continuous glucose monitoring? I certainly understand it more around infusion pumps.
I think it's new, it's electronic device. And then you talk in your approval for non-medical training personnel a challenge. In Tennessee, we not use the continuous glucose monitoring yet because our population and the ER sent out for DKA for hypoglycemic. I think for last 7 months, we only sent out for 1 DKA. And this patient actually is brand new diabetes. He did not see our physician for 3 years. He did not know that he got diabetes. And he come to the point that he put himself to DKA. So we not use that this CGM in Tennessee, but I think if in the future we had recurrent same patient or group of patients go out to the ER, hospital admission, we can use that justification with, hey, this patient is not well controlled. We do everything we can. I think a new technology can help us to provide the best care, reduce ER SNL, and also, of course, will reduce the transportation with security. That they will approve for us, but in Tennessee, we don't have, luckily, knock the wood, we don't have much ERCNL for hypoglycemic or DKA at all. But I know that the other program bring their justification to the DOC, and I think some program that they approve for that. And I know Becky Luth is the head of advocate for that. She have a talk and show how significant positive impact for this device in correctional setting.
I have heard that some security is concerned about patients deconstructing the sticker part of the implant, the part that has the needle in it. I've heard
And making
of concerns about that. But my understanding from places that have actually implemented this is that there is enough tracking of those users that has not been a significant issue. And yeah, so there's a comment in the chat that the CGM doesn't have a needle, it's a small catheter. Yeah, but there is concern by security of poaching for the parts. So but again, my understanding from the places that have these in place, that has not been a significant issue, that poaching of anything causes malfunction, and malfunction causes reassessment of the patient.
Excellent.
One of the questions that come up is how do I get a hold of your slides? And I've published in the chat area both my email and Dr. Nguyen's email, and he can make a choice about whether or not to distribute. The ACCP has chosen to sort of stay out of that loop, and so I can help you be in touch with Dr. Nguyen if you lose his email, and then he has to decide in what format to share his slides. And I've seen it shared as a PDF, and it's usually not a big issue. There
Yeah,
was
just send me an email, and I will send this as a PDF format. I have no problem. I think knowledge needs to be shared so we can provide a better care for our patient.
It is in the chat section. The other question that's in the chat has to do with Dr. Kaplan telling us about Boulder County Jail, and Exagliflozin being their go-to because of just it's only $27 a month. There's hardly anything out there for under $1 a day, especially the newer medications. I wondered if they got that rate because of some special contract, or if that's because this medication in particular is less expensive. And I'd like, so Dr. Nguyen, if you know anything about this particular medication, and Dr. Kaplan, if you know anything about why it's so inexpensive at the Boulder County.
Yeah, I don't know why it's so inexpensive. Boulder County uses Diamond Pharmacy. It's a national pharmacy. What I learned about this med is that it's another SGLT2, but it does not have the same data, as good data as the rest of the class regarding heart failure.
Well, it's newer too.
Right, yeah, and renal
2023.
So presumably it'll be a class effect, but we don't know that for sure.
Good to know, sir.
And
I think the cost is, luckily in Tennessee, the contract will DOC pay for the medication. But even though if not the contract pay for the medication, for the patient best interest, we still approve for that.
Yeah, that's going to be variable according to systems and according to
Yes,
money people and goodwill even. So I'm looking through the chat area, and I think we've answered all the questions. Anybody else with further questions on this or anything? And remember that our contact information is in the chat area right now, and I think that will still be available on the recording, but I'm not sure about that. Anybody else with anything, any questions or comments about any of these therapies? These were not available when I was first practicing medicine, and even, I mean, the topic of insulin pump came up from time to time for difficult to manage diabetics, but I finished my corrections, my hands-on correctional experience back 5 years or more ago, and to my knowledge, nobody was approved for an insulin pump by that time. I think that's what I heard you say about Tennessee, Dr. Nguyen.
yes. We have not approved any insulin pump in Tennessee. We manage diabetes by long-acting and pre-meal short-acting.
Dr. Nguyen, how important do you think this is for inmates that want to lose weight? You know, they will come in, they'll say, in our clinic, they may want to lose weight and they want to use Ozempic or one of those. I know that's not something that I would put into try to get approval for, but how important do you think that they are used, or do you think they should be used in that situation?
So I think in that situation, just follow 101. That means the patient have to fail the other conservative management, right? The first, diet, exercise, and the next step, we have to put some different medication compared to GLP-1. I think outside words, like I think if I still remember, I have to describe Ally, the over-counter in Walmart before insurance can approve for patient GLP-1. So we had to document stepping that the patient tried the other conservative management and then still fail. And right now the patient has comorbidity for, if you say the patient has heart attack in the past, and if you and maybe stroke in the past, and you send to Dr. Rich, yeah, I need this medication, I think Dr. Rich have to approve for that, because GLP-1 it's not only for losing weight, but also multiple study and research so that reduce major cardiac event, so the patient qualify. They have to be approved. That's correct, Dr. Rich?
So
Thank you.
Yeah.
So currently, community standards of care are changing, and certainly morbid obesity with comorbidities is more likely to be to have those drugs approved for treatment. At this point in time in Tennessee, we do not have anybody on GLP-1 strictly for weight loss. They must also have a diabetes diagnosis. Also, remember that these drugs are not without risk, nor are they 100% effective. There is a very high percentage of patients who have non-responder status, where they lose less than 5% of their body weight. That is not being acknowledged regularly by discussions of these drugs. It is, I think in some cases, up to 30% of people are non-responders in terms of weight loss. Now, they still may get the A1C benefits and glucose control benefits, but their weight may not change significantly. And it is yet to be seen if that decreases their risk of other comorbidities. So that is an issue that we need to recognize. And again, there are other side effects. So at this point in time, I do not foresee it being a reasonable option for obese individuals who don't have other medical comorbidities that would warrant their use.
And then another emphasize that when you use this medication and then yes, it had you have diabetes, you use this medication, you lost weight, but you have to remember most of the time it reaches about 40, 60 pounds as plateau. You don't lose any more weight. So it doesn't mean that you explain for the patient. It doesn't mean that you took that and you continue losing weight. No, it will plateau at a point. And I think usually Ozempic reach out about 40 to 60 pounds average, that range.
My understanding, you have to stay on the drug to keep the weight off.
Yes.
That's correct. And that's the other reason why having another medical comorbidity in addition to the obesity is important, because you're going, this is for the long haul.
I have a question for the audience. If somebody knows of somebody who will do a grand rounds for us about the treatment of obesity in the correctional setting, I would love to find somebody who can discuss that topic with us, and I think it would be very well received. So if you have anything, you have my email. And also I'll just say that thank you, Dr. Nguyen, because these sessions are absolutely free to all comers, and the speakers don't get paid. So Dr. Nguyen did this like every speaker who speaks for us in these sessions out of the goodness of his heart and the willingness to share information with colleagues. If you have something, a good talk in the bag that you've already got prepared, or something that you are looking at preparing anyway, and you're interested in doing it with a national audience, for whatever reason, There's self-serving reasons to do that, and there's purely goodness reasons to do that. If you know of anybody, or if you have a session that you can suggest to us, we're always looking for good speakers on pertinent topics. And I'm hopeful that one of you will speak up at some point, either in this session or through my email, and help us to plan future sessions. And please, if you know somebody who can address the management of chronic obesity in correctional settings, we are most interested and have been asked to put on a presentation like that. I just don't know of anybody who can do it at this point. So that's not a guilt throw. It's just a plea. If you've got somebody and you can help, that would be awesome. Thank you.
Thank
And
you.
otherwise, I hope to see as many as possible at the National ACCP Medical Conference in Salt Lake. The agenda is online, the registration is online, and it's still not too late to get some discounted things. And I'll just thank Dr. Nguyen, unless there's somebody else with comments. Hearing none, thank you very much for attending, and it's good to see so many of my friends here. Thank you, and take care. Signing it off.